Good afternoon, everyone, and thanks as always for joining in. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled Variants, Vaccines, and Epidemiology of COVID-19. As we feel the crisp air of fall and approach our second Halloween, the real-life nightmare of the COVID-19 pandemic is still a major force in our lives. We continue to seek news, signs, and portents to help us predict the future. As we learn about this virus and its evolution, and the scientific community continues to push for innovations in the prevention and treatment of COVID-19 disease and its aftermath, we are so grateful for the updates from frontline scientists and public health leaders here at this speaker series sponsored by the California Medical Association and California Health and Human Services. Next slide, please. This is our disclosure slide. Just recognizing that one of our speakers today does have some disclosures, but his talk will not focus on the content of any of the things that he discloses. Next slide, please. This is our agenda today. Next slide, please. And just a reminder, we do offer CME for the speaker series. These are our objectives today, and please do complete the survey at the end of, which will be sent to you at the end of this by this evening, and then you'll be able to get your CME credits. Next slide, please. We're going to begin today's webinar with a presentation we're really excited about from Dr. Christian Andersen, who is a leading researcher, thinker, and communicator on the genomics of COVID-19. Dr. Andersen will be followed by our frequent guest, Dr. Erica Pan, our state epidemiologist, who will review the epidemiology of the disease, the progress of our vaccinations in our state, COVID-19 variants from her perspective, among other things. As always, please submit any questions you have by using the question box in the control panel, and we'll try our best to be able to answer as many as we can. Right now, we're going to hear from Dr. Christian Andersen, PhD. Dr. Andersen is a professor at Scripps Research and the vice president of the Viral Hemorrhagic Fever Consortium. Over the past decade, he has spearheaded large international collaborations investigating the emergence, spread, and evolution of viral pathogens, including SARS-CoV-2, Zika virus, Ebola virus, West Nile virus, and Lassa virus. Christian earned his doctoral degree from the University of Cambridge and performed postdoctoral work at Harvard University and the Broad Institute. In the interest of time, I'll leave his impressive bio there, but as I mentioned before, he has led cutting-edge research on the genomics of COVID-19 and contributed greatly to the academic and public conversation on the virus and its evolution. So Christian, take it away, please.
Great, thank you, Kim, and thanks for having me on today. So I'm gonna give a brief overview of the genomic surveillance program we have here in San Diego, and also give some insights on some of the things we're looking at, some of the things we have found so far. But generally speaking, just giving an overview of a genomic surveillance program that has been active since the very beginning of this pandemic, and which builds on more than a decade of just understanding how viruses spread, emerge, and evolve in human populations. Next slide, please. So yeah, as Kim mentioned, I have some consulting incomes from various biotech entities. None of these are relevant to today's talk, so there's no conflicts here, but these are my disclosures. Next slide, please. So the kinds of questions that we're interested in are quite diverse, I will say. They begin all the way back from emergence, understanding how do these viruses, novel viruses, in this case the novel coronaviruses, but really any virus, jump from a zoonotic host into the human host and the human population, and that's the emergence we're talking about. And genomic surveillance, the idea where we sequence viruses from patients at a representative aspect across the whole population, can answer questions going all the way back to understanding when did this get started, how many times did it enter the population, and then really importantly, we take it from there and trying to understand the transmission of that virus in the local community. Understanding, for example, in the very beginning of the pandemic here, the question of how many times was this introduced into the human population, and is it sustained by human-to-human transmission of repeated spillovers, is something we got really early insights on from the genomic sequence data shared out of China, and it very clearly showed us very early evidence of the human-to-human transmission aspect of this virus. That's all obvious to us today because, of course, we know a lot more about COVID-19 and SARS-CoV-2, but back then were really some of the most key early insights that we got into that. As the virus then spreads from these local outbreaks into larger scale epidemics, and in this case pandemics, that's when we're talking about the spread of the virus, understanding how does it spread through communities, and really importantly, also understanding what factors are driving that. Is it things like travel? Do things like border closures work? What happens if we close down the pubs versus closing down their grocery stores, for example? And we can understand how do these factors impact the spread of the virus, which is obviously very closely related to the transmission. The last thing that we try to look at is the evolution of this, because now we're switching away from what are really epidemiological questions back to what are much more basic scientific questions around the virus and understanding the evolution. How does it evolve over time? How might new variants emerge, and how might they impact things like transmission and spread, immunity in the population? What are the selection drivers here? So those are very broad questions we're trying to address, which just generally speaking has to do with this virus and other viruses in the human population. And again, just to summarize, what we do here is that we sample from individuals out in the community that are infected with the virus. Depending on the virus, we might sample from reservoirs too, or vectors. But here we're only sampling from humans, and then we use these to create these phylogenetic trees based on the sequences of the virus, and then we can connect all those together to understand these kinds of questions. Phylogenetic trees, think of these as basically family trees of the virus. That it just shows how the different viruses are actually related, the different sequences of the virus. Next slide, please. So Kim mentioned this too. This used to be, so this field of genomic epidemiology is a pretty small field, at least until recently. And I happen to find myself in the sort of early stage of some of the more larger scale usage of genomic epidemiology about a decade ago. I trained as an immunologist, sort of got tired of that and sort of switched into this field of molecular evolution, understanding viruses and the spread. A lot of that work is built first on Lassa, was the first virus got interested in. Then as the West African epidemic of Ebola took off, where I worked and we worked for many years, very focused on Ebola and Zika as that entered the Americas here in the United States, and more recently also West Nile with some large-scale collaborations across the country, as well as, of course, SARS-CoV-2, which a lot of that work is focused here in San Diego and California, but a lot of what we do is much more worldwide from that. Next slide. So just to give you an overview of what we have been doing here in San Diego. So again, this builds on more than a decade of experience doing exactly this type of work. So this is a program that sort of just got tacked on to what was already in place instead of actually having to start some of this from the very beginning. So we established this in February 2020. It's a very close collaboration between the County of San Diego here, as well as academic institutions, UCSD and Scripps Research, the primary ones, but also the local hospitals here, like Scripps Health, Rady Children's Hospital, Sharp Healthcare, as well as also UC San Diego Health, and generally speaking, all the different entities that we have here in San Diego County, with a very, very close collaboration between all of these institutions. And this is all funded by the NIH as well as by contract from the CDC under their SPHERES program. Now, what we do is a couple of different things, and as part of this search collaboration, the first thing we focused on was really to get testing ramped up. So we had a lot of early focus on being able to do both diagnostic testing efficiently and at scale and cheaply, but also expanding that into screening programs with schools and workplaces, including here where I am myself, that relies on the technologies we have developed around that. And a lot key to that has been miniaturization. So where you go from pretty large sample volumes down to just a couple of microliters, which really allows you to massively decrease the cost and importantly increase capacity, because all of this is robotics. We then couple onto that the large-scale sequencing efforts, which we have been developing for many years, the Arctic protocol, amplicon-based sequencing, part of developing that for Zika, and then adapted that to SARS-CoV-2. And by now, it's about $20 or so per sequence that we can generate here as part of search. That has given us about 30,000 genomes dating back to the very beginning, again, February 2020. So it's pretty consistent over time. And right now we're sequencing about 20% of cases here in San Diego across all efforts. Those are primarily search, but also the county of San Diego doing their own sequencing, and also Helix together with Lumen doing a lot of sequencing here. Importantly, too, is that we have the whole computational infrastructure built up around that. One of the main programs that we and others use to assemble viral genomes, so go from sequence data to an actual genome, is IVAR, which was developed in our lab, as well as Outbreak.info, which some of you might have used to visualize the genetic sequence data, understanding the variants, how they're spreading, but also understanding just epidemiological data, for example, in context. So these are all efforts that come out of our initiatives here. So we sort of cover it all from the initial sample collection all the way to the visualization and analysis. Next slide, please. So some of the things that we do is that most of the epi side of this integrates directly with all the efforts from the county, from the state, and from the country, where we try and make the data useful in real time. One big aspect of this is simply just sharing the data, which is something we have been spearheading since the very beginning, not just with SARS-CoV-2, but all the other viruses, which is simply sharing all the data in real time publicly, which most labs do by now, as things like GISAID and CBI and other places. And then we can then pull back down that data. One thing we do is that we have developed dashboards that are really specific to San Diego, also to Baja California, where we have collaborations that allows people to go in and look at things like variants. The example to the left here is just showing some of the main variants here. The California variant first, and then Alpha came in, and then of course more lately Delta came in, and you can see the displacement here of these different variants. What we also do is that as we produce the sequence data, it's a couple of thousand or so sequences a week. We send out weekly emails to the providers of that breaks down with what are your variant calls this week, here's all your data, here's all your metadata, here's where you can access it, here's where you can see it in context. So that gets sent out every week as we have generated the data. Importantly, as I mentioned, we also developed Outbreak.info, which is now a resource that works for any location in the world, and it just pulls down all the data from GISAID. It's about 4 million genomes or so. We do that twice a day, analyze all the data, and then visualize it to break down into, for example, what are the current lineages circulating, and so on and so forth. And I'll say that this really sort of requires everybody to share the data so everybody can be visualized. And this is why one of the main reasons why it's so important that all data is shared publicly, and importantly, all that data is associated with metadata so you can actually make sense out of it. Next slide, please. So going away from the epi side of what we do, we also do a lot of academic research, of course, on the data itself. Those are a little slower, they result in academic publications. Again, as part of these big teams with all collaborators engaged here. And much of this has been focused on the genomic aspects of this. On the left-hand side here, understanding the spread and the drivers of spread here in the United States. From the very beginning, one example from New Orleans here at the very beginning of the pandemic, but also to understanding things like B117 or the Alpha variant and understanding the spread of that in this country. It also goes back to the question of emergence, and some of you might have seen my names around that, which try and understand the proximal origin of this virus and just understanding what are the most likely explanations for how a virus like this ended up in the human population. And then really importantly too, also associating all that with the clinical data out of the hospitals, understanding things like breakthrough infections, understanding what's actually driving when we're talking about the evolution of the virus. Next slide, please. So I mentioned these phylogenetic trees or family trees of the virus. And if we look at this picture here, it just shows sort of a snapshot of where we are today with this virus. By now, we have multiple different lineages, things like alpha, beta, gamma, delta. But it all started with just one single virus, possibly with two single viruses that then ended up actually spreading through the human population. So in the beginning, there was very little diversity. Now there's a lot of diversity. And next slide, please. And we can visualize this, this one again on outbreak.info, where we can sort of visualize, well, if we classify these different lineages into these variants of concern and variants of interest, the Pango lineages, and Pango is really the team from the United Kingdom that have been driving this along, is a good way of just visualizing how might this change over time. And what you're looking at here is exactly a plot like that from outbreak.info. In this light blue, what you can see is the spread of the alpha variant here in, I believe this is from California actually, so this is all the California data, is that you see the spread and displacement of all other lineages by the alpha variant, only to then be displaced later on by the emergence of the Delta variant and sublineages of Delta, which some of these different other colors are sublineages of Delta, which I would say is happening exceptionally fast. Next slide, please. And I think this is a really important point that I have been trying to make for a very long time, that there was this idea that this was a slowly evolving virus, where here's one example from Twitter last year where I made it clear that it is not. And it's very clear from the data that it really is not a slowly evolving virus, and we shouldn't assume it is. We all know that now to be true, but I think it was a big mistake to think that this was not going to be like flu. This is just going to be slow and it's going to be stable, where we actually knew that there is very little chance that that's going to be true. We know that from the common cold coronaviruses, but again, this is a completely novel virus, highly adaptable, just recently emerged in the human population. We should assume a lot of evolution, and that's exactly what we have seen. What's also important to remember here is that when we talk about evolution, we talk about different things. We talk about things that are specific to the virus, the evolutionary rate. There's a lot of focus on the mutation rate, which is the way at which the virus mutate once it replicates in cells, which, yes, it is lower for SARS-CoV-2 coronaviruses because they're proofreading, for example, flu, but the mutation rate doesn't really matter at all. What matters is what you see out in the population. As you see the single individual infected here and the other individual infected there, how many mutations do you find between those? And that's the evolutionary rate. And there's where we see a lot, especially with the variants of concern and variants of interest, where we see huge leap in evolutionary space when these have emerged. What we also have to remember is the mutational supply, which is critically important here. It's just like, how many chances do we give the virus of actually evolving? And that directly links to just the number of cases. If you have a ton of cases, you have a very high mutational supply. If you have few cases, you have a low mutational supply. And the mutational supply is really what matters here. If we give the virus a lot of chances to evolve, it will. If we don't, it won't. So I think it's really important. I'm going to talk a little bit more about that we keep this in mind. The other thing we need to consider is mutational tolerance. It just says, well, if you throw a random mutation in here, how tolerant is the virus of that particular mutation? Again, we should assume, based on what we know from other coronaviruses, that probably SARS-CoV-2 is quite tolerant of mutations, and that's exactly what we are seeing. You can throw a lot of different mutations at this virus, and many of them are adaptive. They might be beneficial, but they certainly don't seem to do too much to the virus in terms of lowering fitness. The last thing and critical aspect, which has nothing to do with the virus, it's everything to do with what's around the virus, is the selection and the fitness landscape, which is changing over time. And I'm going to mention this in the end of my talk. But it's really important to understand that really what matters too is not just what the virus is doing, but of course also the environment in which the virus finds itself. Next slide. So going back to outbreak.info, again, we've tried to make some tools where you can visualize this on your own. This is just showing you a snapshot of the spike protein and then the variants of concern here, highlighting the kinds of mutations that we see across the spike protein. And these are all the non-synonymous mutations, the ones that actually change the amino acid. And what you can see is there's a huge number of mutations, some of which are shared, some of which are not. But this is a lot, right? So if you have this idea that this is a slowly evolving virus, you have this idea that this is slower than something like flu, is simply not true. It's faster than flu for most part, and we see a lot of mutations by now. So it's really important to keep in mind that this is not a slow moving target, right? In fact, this is a very fast moving target. And I think really importantly, when we look at these displacement of lineages with these variants of concern, is something that only takes just a few months. Delta has basically taken over the world in just a 3-month period of time, which is exceptionally fast. We're talking about displacing fully, which is something for flu that takes at least a year and typically longer than that. Is something we've seen just in a matter of months for this particular virus. This is very, very, very fast and at a scale I can't see that we have seen previously. Next slide, please. So going from that and saying like, okay, we are interested in understanding not just the evolution of the virus, these variants of concern, we're also interested in just understanding different aspects of just the epidemic itself. How is everything connected? And just a couple of examples for you showing here the studies that will come out of this. But what this is showing, for example, is the connectedness. Because we have these genomes, we can look at the different kinds of connectedness and we can actually quantify that. And here we're just looking at how connected is San Diego to places around us. And then the lower the graph here, the more connected they are. And what you can see here in green, and then this is over time. What you can see in green here, for example, is Imperial County, neighboring county, right? Very connected. It's basically a single epidemic. We look next at Baja California across the border, also very connected. In fact, just slightly less connected than we are to Imperial. Interestingly, if you look at Los Angeles, for example, which is also neighboring here, close by, is that we're actually less connected, phylogenetically speaking, on the virus perspective with Los Angeles than we are with Baja California. It's probably what you expect when you know the movement of people, right? But this really shows as well. And then as you go further up north, you get less and less connectedness. Of course, this is just looking at San Diego, right? But we can do this across the whole country. We can do this across the whole state. We can do this across the whole world. Next slide, please. Once we know that, what we want to try and figure out is that, well, if we can establish connectedness, what might actually drive this kinds of connectedness? And there's many things you can think about here, things like travel, things like climate, things like what kind of jobs do people have? How do things change over time? And we can just classify these as a set of covariates and saying which ones actually seem to correlate with connectedness and spread. One specific example here we're looking at is, for example, did border closures do anything in terms of stopping transmission? The answer is probably not, certainly not more long-term. It's also not a good solution overall. But again, this gives us a framework in which we can try and understand and analyze these particular questions. Next slide, please. And then also taking it from here and then going down to the really local level of saying we have a university outbreak here that led to a few thousand cases. What actually caused that? Well, we can sequence a subset of those and see how they're all connected. If you look at the bottom right corner here, what you see is basically what this shows is there was just a single virus that came in. Importantly, not from the San Diego community, it came from somewhere else. So, and then this led to this whole cluster at this single outbreak here, led to all those ensuing cases. So we're talking about a single case here coming in onto a university campus and then leading to thousands of downstream infections from that. It just takes that one event that is successful leading to the entire outbreak. And I will say, if you read our paper from New Orleans, it was actually exactly the same. The entire first wave was caused by just a single introduction of the virus into the New Orleans area. Next slide, please. And we then take that further and also saying that, well, but when you have new waves, is it that we see lingering transmission of previous variants? So is it that new variants come in and displace later variants? And this is one example from Louisiana, where we can show that actually later waves are caused by new introductions and not really what was already in the local area, which is no surprise because people move around, of course. But again, this gives us a way to really analyze this in detail. Next slide. So just to go back to this particular point, and I'll finish on this with just a couple of things of what we might expect to happen next, is that, again, remember, this is not a slowly evolving virus. It won't stop evolving either. It will continue, right? Remember that the factors the virus is in charge of, things like what's the evolutionary rate and the mutational tolerance, But then there are the things we are in charge of, which are things like mutational supply and things like this selection and fitness landscape, which is going to change. Next slide, please. So if we think about some of the expectations I will have here is that the virus is now endemic, which means that the pandemic will really never be over, right? There won't be an end to the pandemic, but we will sort of transition from a pandemic period to an endemic period. And the question is, what is that going to look like? Well, we don't really know, right? But the virus won't disappear. Importantly, too, is that the virus might actually be establishing new reservoirs, too. It's not just that it stays in humans. It might actually move outside humans. We have seen the deer, for example, that we see very high seroprevalence of this virus. So presumably, this virus is now actually living in all kinds of other animals, some of which we have identified, most of which we probably haven't. We have to remember that the virus will continue to evolve. The question is how rapidly. We've seen a lot of rapid evolution. Would we expect that to continue? I think the answer to that is probably no, not necessarily. But the problem is we don't really know when we might expect less or slower evolution. Are we already there, or is that 2 years from now? We don't really know the answer to that. But for now, we know that at least we know it's going to continue to evolve, and we should expect significant evolution of the virus. What's really important too is that when we talk about this selection landscape, the fitness landscape, because there's this idea of like peak fitness, but the problem is that the landscape is really what determines that fitness, and that is changing. If we're looking at the variants like especially Alpha was selected for increased transmission, things like Delta probably primarily because of increased transmission too, but also some immune escape. The problem is that as that landscape is changing, it's going to move much more towards being able to escape vaccines, for example, than and immunity, and much more so than transmission. Plus, there is an upper bound to how transmissible can a virus be. It's just we don't know how close we are to that upper bound. We might be there. There might still be twofold difference that it can still reach, right? We really don't know. But what's important here is that we should expect it to move much more towards immunity being the driver of selection here. That might sound bad, and some way to interpret that to say, well, then you shouldn't vaccinate. Of course you should, because the solution to this, if trying to avoid this, is vaccination, right? And that's because of the mutational supply. The less chance we give the virus of bumping into a vaccinated person, the better, which means we need as many vaccinated people as possible and as a uniform distribution of those individuals. The more we can vaccinate, the less mutational supply we have, and way less likely that we will actually see escape. This perfect like pot of having 50% vaccinated, 50% not vaccinated, or having whole parts of the population, like kids, for example, not being vaccinated, is not the right strategy here, right? It really needs to be uniform, and again, is really the way in which we can dramatically lower the risk of this happening. Last slide, please. So with that in mind, I think the focus from my perspective has always been the case is that we really need to focus on incidence. I've seen this complete move towards like, well, as long as people are not ending up in hospitals and deaths, we're winning here, which in my opinion is not a long-term strategy. The long-term strategy is really to focus on how do we lower incidence, i.e. how do we lower the number of cases? And we have the tools, vaccines, boosters, which we need to use, things like antivirals coming up, tests, masks, and support. And the question is, are we going to use all of those? Are we only hoping to say, well, let's try one of those and see if that will work out? Because generally speaking has been our strategy here, with a lot of people working incredibly hard, including everybody on this call, right? But the problem is, again, the willingness to go all out and saying, let's do everything we can, has really been lacking in our response so far. And I just wanted to illustrate that on the left-hand side here, where if we look at the daily cases over time, where we can see relatively distinct waves here, but underneath it, it's the daily number of deaths. And what you can see is that if you compare our two major, ignoring the first wave, but the two major waves, the one in the middle and the one to the very right here, where we have good testing capacities, that we can pick up most people that get infected. What you can see is that the difference between how many deaths did you have in this last wave, the ratio of cases versus deaths versus previous waves, is really not all that different, which means that in a world in which we have really effective vaccines that will definitely prevent you from dying from this, we're still seeing the same number of deaths that we did previously. That's not great, right? And I don't think is what we should hope for in the future. So with that, I'm going to stop my talk here, and then we'll take some questions after the next talk.
Thanks so much, Christian. We do have lots of great questions, and we will look forward to those after we hear from Erica Pon. Welcome back, Erica. Again, our state epidemiologist and our regular presenter here for our virtual grand round. And Erica is going to share the latest information on COVID-19 in California.
Great, thank you so much, Kim, and thank you, Dr. Anderson. You teed me up very nicely, I think, for a lot of things that I work on as far as and really making the case for why a lot of all these things, vaccinations and public health measures, are really important. Next slide. So I'll do kind of some of my usual update on where we are in California as far as trends, a little bit of highlights on pediatric data, and then of course, what we really are focused on now is vaccinations. How are we going to get out of this pandemic and get from pandemic to endemic? As Kristen just said, we need to vaccinate. So I'm going to just talk a little bit more about that. There's a lot of approvals and discussions happening at the federal level that are happening the next few weeks. I'll show you kind of a timeline of what we're anticipating. A couple things about our new requirements in the state. And because we've talked today about variants, wanted to highlight another kind of specific outbreak in California that was in an MMWR recently, and then a little teaser at the end about some other innovations in COVID-19 detection. Next slide. So this is kind of a nice show of the timeline over the summer. We were very happy right before our reopening in June. We were one of the kind of blue states there as far as the lowest on these CDC levels of transmission. Blue is low, yellow is moderate, orange is substantial, and red is high. And then you can see here as Delta sort of moved through the country, we got hit really hard, beginning in July, and then certainly in August we became in the high levels of transmission. And now we are one of the first and certainly one of the lowest rates, especially in the continental US right now. And I think that's largely because of a lot of the measures we've been talking about here. So we are making great progress, really proud again of Californians and California for having one of the lowest case rates in the nation. Next slide. This is just an update kind of our daily dashboard, so you can always look at our COVID-19 site or our CDPH site and see these numbers. We are up to about 79% of our population that's eligible has had at least one dose, and about 70% are fully vaccinated. But those are of the eligible. So as we talked about, this virus likes to find reservoirs, and we need to vaccinate the unvaccinated. So we'll talk more about that in a bit. And our daily average and our per capita case rate is around 12 now, new cases per 100,000 per day. So that is, if you remember our old blueprint, that would have still been in the high purple range. That used to be cut off at around 7. So we're still, we are learning how to live with this virus, and I think people are becoming a little bit numb to these numbers, and we're doing so much better than we were, but we still have, what would have been deep purple in the past. So, but thankfully a really good trend. And then as pointed out as well, deaths are a lagging indicator. So, but I think, that was a very sobering graph to see about worldwide cases and deaths. I am really proud again, as far as California, that we have one of the lowest death per capita rates over the course of this pandemic. And I do think, again, a lot of that is from a lot of the strong public health measures we've had. And then test positivity is another indicator, and sometimes an early indicator, but of course, dependent on testing volume. And we're down to around the low 2% in our test positivity. Next slide. And again, just showing you kind of the course as well, of our first 2 large surges in California. In blue are the cases, and then our most recent Delta surge, and then hospitalizations, and then the deaths are the red here, and the ICU. And you can see here in California, at least, again, some of what I was starting to allude to, in that our case surge this last summer was higher than last summer, but our deaths look like they peaked maybe around the same or a little bit lower than last summer. So I think, again, a lot of that is due to our high vaccination rates, to masking, and a lot of other public health measures and interventions. Next slide. And then, what's happening with kids. So here you can see for all ages incidents, and this is kind of pulling out from just in this year, 2021, April till now. So the 18 to 49-year-olds, sort of young adults, was still the highest and the highest peak at the peak of this. But you can see that the 0 to 17-year-olds sort of started to catch up with that age group and had a high incidence as well. And obviously a lot more testing has been happening in that age group as well. And then when you pull out the under 22 years of age, you can see that both the 5 to 11-year-olds and the 12 to 17-year-olds are where we're seeing the largest increases in incidence. And again, a lot of testing happening, so we're detecting them. What we are seeing as well, and I don't have a graph on this part, but is that unlike a lot of other parts of the country, pediatric hospitalizations have stayed very low in California, so less than 2% of all of our new admissions. And even though we are detecting more cases, we have not seen the kind of overwhelm that other states have seen who have low vaccination rates. Next slide. And another kind of interesting thing people have been looking at across the country, what proportion of cases are we seeing in pediatrics, and is that increasing? And so I think one way to think about this and look at this again is that we are, as we vaccinate more age groups, and of course we vaccinated our most elderly first, so I think that's the other reason we are seeing lower deaths now in this surge compared to previously, but you do see, again, this virus finds our vulnerable. So once we started protecting our vulnerable elderly population, it's looking for our others that are unvaccinated. So you can see, maybe I'll just jump to the lower right-hand corner here to see that under in our pediatric cases, you can see that our 12 to 17-year-olds, which is the blue here, the proportion has gone down, and we are seeing an increase in 5 to 11-year-olds, and pretty steady in the 0 to 5-year-olds. And of course, there's less testing happening in the 0 to 5-year-olds, and less with symptoms, and of course, there's less asymptomatic testing in younger age groups as well, except for now that schools are open and we're seeing a lot of screening testing, which is great to detect cases, but that's kind of the trends we're seeing in California. Next slide. And then MISC, so this is really important. What are the reasons we, some people are saying, well, pediatric hospitalizations are not high, kids do pretty well with COVID, why are we working so hard to protect them from COVID? So here you can see both the national data as far as peaks of MISC, and again, a reminder that MISC is actually a post-infection inflammatory response, actually. So you see the peaks lag from the actual case surges. And so we have a lot of delay here too, especially in the US curves, which are the bigger graph on the left. And then we now have on our website, so you can look at our CDPH website, this curve, epi curve as well of MISC in California. So we've had over 600 cases in California of MISC, and actually this is the latest data is another 15 or so cases in addition to the ones reported here, which is, I think the table on here was from a week or two ago, and 6 deaths. And over half of the kids who've had MISC have been intensive care unit admissions. And I think also really important to know, half of these kids had no underlying medical conditions, and many had, very mild COVID-19 and then later developed MISC. The median age is similar, both California and statewide, 8 to 9 years of age, and then a male predominance there. And we, again, will be updating this data a couple times a month on our website. Next slide. And then also, what are we forecasting for the winter? We're trying to actually start to incorporate some of this data and other looking at both mild and severe flu seasons, and what are we seeing now? So we are seeing in our respiratory surveillance that a lot more rhinovirus, which is on PCR positivity, it looks the same as enterovirus or rhinovirus, but those have continued to increase. And we are seeing some increases in paraflu as well, other human coronaviruses, and other flu-like illness. So we are worried, especially as people do go more indoors over the winter, and if people start relaxing their mask use in certain high-risk settings, that we're going to see even more, not only COVID-19 transmission, but other viruses as well. Next slide. Also always important to emphasize again, the huge difference in cases, hospitalizations, deaths between those who are unvaccinated versus vaccinated. So this kind of shows you that contrast in California up to the end of September. And roughly our cases, the increase in risk is about 7 to 8 times more likely for the unvaccinated cases, for cases to be unvaccinated versus vaccinated, and then deaths is around 17 or 18 times, and hospitalizations has been in the teens as well. So a much bigger, these surges have definitely been driven by the unvaccinated. Next slide. Moving into a little bit more of a smorgasbord of different tidbits that have been hot off the presses. So Merck is applying for an EUA for a new oral antiviral. So this will be the first oral antiviral for COVID-19. The indications that they're applying for are for adults with mild to moderate disease who are at risk for progressing to severe COVID-19. So the elderly, people with obesity, diabetes, or heart disease. And the submission is based on their phase 3 trials that showed reduced risk of hospitalization or death by about half. So more to come on that, but that is definitely an important and exciting development. It is also important to note that even if and when approved, they only have about 1.7 million doses that they're, I think, able to initially distribute. So given that even our state alone is 40 million people, it's a very small amount. So it's going to be in very short supply, at least in the short term. So again, this is not the solution. I think the solution is vaccines, but it is helpful to have another tool in the toolbox for treatment once people are infected. Next slide. How are we doing as far as vaccine administration? So this is kind of our epi curve of vaccines, and you can see, from when they first became available and in short supply, and then our peak administration was in April. And that was when it was open and eligible. There was enough supply for everybody and eligibility was open to everybody. And then it's been decreasing. We had some increases in first doses and new vaccinations throughout this Delta surge this past summer. And also as we've increased vaccine requirements in different settings. And then at the bottom here, you can see what's happened. So September 24th was the date when boosters were approved by the FDA and the ACIP for the Pfizer booster. So you can see that we did have a big bump there right around the time that it was approved, but already a big drop off. There's of course a data lag here as far as the October 11th date, but we're seeing unfortunately a decrease again in new first doses of vaccine administered. Next slide. And actually, one other thing I'll speak to as far as boosters is we were worried a little bit about capacity as far as how many people would be eligible and what the demand would be. And the total numbers, we've had, I think, less than 1 million people who've actually even gotten booster doses yet. So we've not at all tapped our capacity, and boosters are widely available in pharmacies and healthcare providers. And I'll talk in a moment about other upcoming timelines in that. But we have been surprised, again, focusing mostly on unvaccinated as our highest priority, but again, want to encourage those who we're recommending boosters for, which I'll talk again in a moment. The other area that the CDC at the end of last month came out with a health advisory, just really wanting to emphasize how important it is for pregnant women to get vaccinated. So either before or during pregnancy, and the benefits of vaccination for pregnant persons and their fetus or infant far outweigh any known or potential risks. So we've seen in pregnant women, and this is true often for many other infectious diseases as well. We saw during the H1N1 pandemic that pregnant people had much higher risk of ICU admissions and death. So with COVID-19, 2 times the risk of ICU admission, a 70% increased risk of death during pregnancy, and increased risk of adverse pregnancy outcomes, everything from preterm birth, stillbirth, and actually an ICU admission for the newborn if born with infection. And the evidence about the safety and effectiveness of COVID-19 vaccine during pregnancy is increasing. So the data, again, continue to show that the benefits far, far outweigh the risks, and that it is very risky to get COVID-19 during pregnancy. So, currently, and right around the time the CDC released this health advisory, less than 1/3 of pregnant people have been vaccinated to protect from COVID-19. So really want to, again, encourage you all to encourage your pregnant patients to get vaccinated. And then just want to always debunk this myth about any evidence that vaccines, including COVID-19 vaccines, cause any hormonal or fertility problems in women or men. Next slide. So shifting back to boosters. So what, I know it's been very confusing. So our team put together this nice chart, which is also on this link here on this slide. But so Pfizer is the one, as was just discussed at the end of September, that was approved for boosters. And so there were kind of 2 groups, those that we strongly recommend get booster doses and those who are eligible and should consider it based on their own individual risk-benefit ratio. So this kind of shows you across the board which ages were approved for the additional dose. So all immunocompromised, regardless of age, are approved. And actually that was also approved for Moderna boosters as well. And that was prior to that end of September date. And then for those we strongly recommend, so it was the elderly, so over 65, and then long-term care facility residents are the people that are strongly recommended to get booster doses. And then the others that are kind of in the may consider category, again, depending a little bit on the specific underlying medical condition, age, or other, we definitely see, again, disparities in our African American and Latino populations, or other increased risk of social inequities are people that should also consider getting a booster dose. And then as far as Moderna and Johnson & Johnson, let's go to the next slide. We'll talk to you about what's upcoming. Actually, first we'll mention pediatric vaccine trials. So again, Pfizer was fully approved with full licensure already, and then the submission for EUA happened last April, and so we've been vaccinating 12 to 15-year-olds. And then, as you all may know, Pfizer submitted their EUA application to the FDA, and so there's a meeting October 26th, the VRBPAC meeting, to discuss authorization. And it's also important to note that the 2-dose vaccine contains 1/3 of the vaccine amount used in adults. So that will be discussed again at the end of the month. And then we understand that both Moderna and J&J are also soon to submit more data on pediatric populations to the FDA. Next slide. Also wanted to just, for a step back on comparing the incidence of vaccine preventable diseases in persons, pediatric persons in California. So we've had over 640,000 cases, and that's of those who have tested positive, right? We certainly have had many who have not gone tested or gone undetected, and 35 deaths of COVID-19 since last March, since this pandemic started. Our estimates on flu are probably about 1.5 million. This is extrapolated data because flu is not a reportable disease. For outpatient or regular disease, but that's our extrapolation based on surveillance data, and 22 deaths in a severe season. So we've already had more pediatric deaths than in a flu season. And then other vaccine preventable diseases, you can see here, pertussis, mumps, meninge, acute hep A, and measles all have a much, much lower number of cases and deaths. This is compared to our 2019 data. And I think just also harkening back and thinking a little bit about the prior presentation, thinking about measles and the attack rate. So measles has like a 90% attack rate if people are susceptible, and we have gone down to these kinds of numbers because of vaccines. And so we need to get to those kinds of numbers with COVID-19 by vaccinating our entire population once eligible. Next slide. So here's a nice timeline that has been put together around these different kind of applications, and then I'm going to focus on this fall period now, both because I know it's a bit confusing and also just to tell you what we're projecting. So as I just mentioned, October 26th, VRBPAC is meeting about the approval and discussion about the pediatric doses. And then the FDA would then have an approval of their recommendation sometime after that. And then ACIP may meet either right away. We just heard this morning they might actually meet before November 2nd. They might actually meet, a day or two after the FDA issues a recommendation after the VRBPAC meeting. So that's for the 5 to 11-year-olds. And then we always have our Western States Scientific Safety Review work group meet soon after the ACIP, just to also review the public data. We have a lot of crossover members of both VRBPAC and ACIP who help inform California, Nevada, Oregon, and Washington about the various recommendations that have been coming out from these federal committees. And then Moderna has also submitted their EUA for a booster dose. That is also going to be discussed along with Janssen & Janssen boosters, and also the sort of what we call mix and match or heterologous doses are all going to be discussed at the VRBPAC meeting October 14th to 15th. And then the FDA would likely issue what their approval is around the 16th. The ACIP is meeting the 20th to 21st, and then we will meet soon after that with the Western states as well. So those are all exciting news that are coming in the next couple weeks as far as other updates on both boosters and 5 to 11-year-olds. Next slide. So just really want to make sure, talking to all of you as clinicians, just, we said this even before COVID-19 with vaccines, we don't want to have any missed opportunities, vaccinate at every opportunity. So really, if you haven't already become a provider that has vaccines, please apply. I'm going to show you some resources and future slides here if you need other resources to help your practice get vaccine, and really try to vaccinate at every opportunity. You all are the trusted providers for your patients, and I think more and more of the surveys show that a direct healthcare provider, people who have an established relationship, are the trusted people to really provide that advice and weigh the benefits and risks with each individual. And really trying to make sure you have a policy to vaccinate any siblings or other household or family members who are present during visits, and not just restrict to who had the appointment, or schedule the next appointment or a vaccine appointment before leaving the clinic. And it is okay right now, every vaccine counts, every shot counts. So even if it means puncturing a vial at the end of the day, we of course want to minimize any waste, but we also want to, again, not miss any vaccination opportunity. And we have a link here as well, just sort of advice about vaccine opportunities and minimizing wastage. And I also want to make sure that clinicians know that there is, that you can co-administer with flu vaccine. So it is time to get flu now as well. We're really worried, as I've shown you, all these other respiratory viruses are on the increase. We've only seen a few sporadic flu detections at this point, but again, concerned it's going to be more of a normal flu season this year, and there you absolutely can co-administer at the same time. Next slide. So other ways you can identify ways to expand opportunities is consider extending your clinic hours, weekend clinics, special events, especially with community partners or vaccine-only visits. And I started to mention, so we have Calvex Grants. So providers who are already participating in the COVID-19 vaccination program can apply for reimbursement for storage units, data loggers, staffing, other iPads or vaccine registration. So please, there's a link on these slides, how to find out more to get small grants for providers who need more resources to get vaccine. There's also a Medi-Cal incentive program. And then also we're always looking for My Turn volunteers to recruit medical and general support volunteers to support vaccine clinics. Next slide. And then just a bunch of different emails and phone numbers and/or resources and links for you as providers to where you can go for additional help about these various items. Next slide. I also wanted to preview a little bit that we are really ramping up and working with schools, local health departments, and other partners to have a fall school located vaccine campaign. So we, again, want to protect our students and our children from COVID-19. We're really prioritizing with our equity lens, students in low SES zip codes, and there are at least 100 schools located in California's most vulnerable neighborhoods, and we'll be also working again closely with local health departments and other school districts to have, more than that, but these are kind of a priority group we're working on. School located vaccine clinics not only have the ability to immunize large numbers of children in a short time frame. Many people harken back to the days with polio vaccine where kids would line up and get their polio vaccine at school. This is, bringing vaccine to where people are. Also really increasing access to underserved students and families where just it's so much more convenient to bring it to where they are so that no family has to make a special trip to another clinic or go somewhere further away. And this will really decrease illness-specific school absences, lower disease transmission, and hospitalization rates in the surrounding communities. So we really want to maximize these opportunities for students and families to stay up to date on recommended vaccines. And some of these will, again, try to do some co-administration of flu vaccine. I think it'll really vary by jurisdiction and resources, but again, there's absolutely no reason not to try to do both at the same time and not miss that opportunity. Next slide. And then just to quickly highlight as well some of our new state public health requirements. So one of the more recent ones was adding adult care facilities and direct care, in-home direct care service workers, hospital workers, and regional center workers who must get vaccinated. And then also a recent one to help really facilitate. We've had over 5 million people download their digital vaccine record. It's been a great resource to, and here's the link again to get that. But in order for people to do that, they do need to have an email or cell phone number. So we've added a requirement that providers must request that information from the patients as they're getting immunized and then submitting it to our immunization information system. Patients are, of course, not required to provide this in order for them to get vaccinated. We do know there's maybe some concerns or hesitancy on patients, but if they are willing to, we are requiring providers to ask for it and to submit it so that that really does help, again, that people can get their vaccine records later if they lose their vaccine card. Next slide. And then also big news recently was on October 1st, we did announce that California will be the first in the nation to have COVID-19 vaccine added to school vaccine requirements. And for all the reasons I was starting to show you and outline to you, that we need to get our kids vaccinated as well, showing you much higher morbidity and hospitalizations from this disease and a lot of other vaccine preventable diseases. So this will be phased in by grade span. So the way our regulations work now, we have certain vaccine requirements already starting in 7th grade for 7th to 12th grade, and then at kindergarten entries. So based on current information and that timeline I just showed you, the requirement will likely be once there's full FDA approval for 7 to 12, it would probably start on July 1st. And then we're absolutely supportive of all local health jurisdictions, local school boards, and school districts who are already implementing requirements ahead of the statewide requirement, but we'll get to uniformity by next school year for sure. Next slide. Also wanted to really highlight, more and more, and I'm sure all of you are seeing this science as well, we really want to emphasize how important getting the most out of masks are. So it's fit and filtration. And again, I showed you all these respiratory viruses are increasing. Masks really help against other respiratory viruses as well. And a lot of us think that a lot of why we didn't see much flu last year is how much masking there was, in addition to not having as many people. We were largely in a stay-at-home or a modified stay-at-home during that time. And during our wildfire season, getting better filtration masks is also helpful to help protect from air quality, poor air quality. So some resources and just tips on this are that, especially in indoor spaces and crowded areas, make sure individuals are wearing a more protective mask. So surgical masks are definitely better than cloth masks. And if you have cloth masks, you want to have multiple layers. And then there's K95, KN94s, or N95 respirators. Or there are other more and more now reusable masks that have higher filtration. ASTM has come out now with some international standards on filtration that you can look up and compare to. So really starting to emphasize and coming out with more and more public messaging to really make sure individuals are providing themselves with the safest protection they can. And just again, reminder that we have different requirements based on settings across the state. Next slide. And then to shift now to a recent outbreak, well, not so recent, it was last May actually, but that was recently published in an MMWR. So in Marin County, there was a situation where there was a teacher who was unvaccinated and who was reading to students who were unvaccinated, occasionally reading to students with the mask off. And the attack rate in that classroom was 50%. So 12 of 24 kids were infected in that classroom. And really just emphasizing again some of what was emphasized earlier about all these other layers of mitigation are important, including wearing masks. And then the next slide shows you that there were also so there were 12 in the classroom and then another 14 cases of other staff, siblings or parents that occurred. And this is where a nice kind of concrete example of where the whole genome sequencing is really interesting and useful to look at. So all of these were Delta variant. This was one of our earliest sort of clues that Delta variant was in California and causing, much higher, much more aggressive transmission than we've seen with prior variants. But what you can see in this phylogenetic tree is that, it tries to color code whether the case was case in the class, case in another affected class. So there were several students that were actually in a different classroom that was 3 grades, I think, difference. There were some siblings and parents that were infected as well. And then there were a few cases that had pretty much the same exact sequence that didn't have an identified link. Aside from, being affiliated with the school. And then there's a few others that had sort of one layer or one difference in their sequence. I think the other time this is useful as well, though, is when we have outbreaks. If you see multiple cases in a setting, but they have different sequences, then you actually know that they didn't transmit to each other, that they were different introductions. So kind of the micro version of what was being demonstrated about introduction of new strains into a community or a region. This is like even within a specific outbreak. So what we're really working on with partners like Christian at the Scripps Institute and a lot of other partners is how can we make this data matching from the whole genome sequencing to the epidemiologic data more real time, so that local health departments can really do these investigations, really understand where's the source, are there multiple sources, and really being able to investigate outbreaks. So really excited about all the tools that we've evolved over time in whole genome sequencing. Next slide. So my last little teaser and tidbit, thanks to my colleague, Dr. Carol Glazer, who happens to be a vet and a Peds ID doc, is that dogs apparently can also detect COVID-19. So there was a Finnish study that was a hallmark about dogs learning how to recognize the distinctive smell of COVID-19, and there's precedence in this with other infectious diseases like C. diff and malaria. Dogs, of course, are non-invasive. They can be rapidly deployable once trained. They can be effective. Potentially relatively inexpensive once trained. They can actually screen large numbers in a short time frame. So just an interesting other innovation that is evolving in COVID-19 detection. Next slide. And the CDC Foundation has recently funded CDPH pilot project for COVID sniffing dogs in schools. So more to come on that. This is kind of a teaser, but just a fun little tidbit I thought I'd share that is being funded in California, and yet other great innovative work on the horizon. Next slide. And with that, I'll stop and we can move to Q&A. Thank you.
Thanks so much, Erica, and welcome back, Christian. I love those last 3 slides because I have a lot of questions related to those 3 things. But Christian, maybe I'll just start with you. And Erica sort of showed that great case study of Marin where sequencing really was helpful in untying what was happening in the outbreak. In a perfect world, how much sequencing, first of all, should we be doing? I mean, I know San Diego's always been a high flyer. Is 20% the right number? And then if you can comment on how we're doing in California and the states in ramping up our sequencing, since we realize that this is important, and how we compare to the rest of the world.
Yeah, I think 20% is overkill. I don't really think that you need consistently 20%, right? No question. I've always said aim for 2% first and then go for 5%. Once you're at 5%, you're in a really good spot. I'll say anything above 10%, again, you're probably overkill. What's important here is that it's representative. If you're very specific on only sequencing outbreaks, for example, but nothing from the community, you're gonna get very low bang for your buck there. So I think that's really important, like representative, and then 5 to 10% is really where we need to be. California is doing well, with the whole COVID-19 program. Of course, we're part of that too, but my lab is not sequencing under it, is important. I think though, what's really important here is that it's not just sequencing, right? It's like, what are you going to do with those sequences? I think the investment in who's going to analyze your data, who's going to tell you that something is up here, is as big an investment, if not a bigger investment, and just simply creating the sequences in the first place. And that's something I've mentioned a number of times that I think needs to be invested in, and that requires money. It requires people, because that's a pretty specialist skill. But overall, just in terms of numbers, California is doing well with the COVID-19 program now analyzing that. But I think, is all of that data going with the relevant metadata on public servers so it can all be analyzed? And do we have a plan for what to do with the data? I think that's something we still need to figure out.
Great, thanks. Erica, maybe I can switch over to you for a second and talk to you about schools. Last month, you sort of reviewed with us how we're doing as a state trying to reopen schools. And I just wonder if you can give us a verbal update on how we're doing. Are there lots of schools closing across the state? How many outbreaks are we seeing in that? And then I'll have a follow-up question on that as well.
Sure, and yeah, I apologize, didn't include, there's a nice website called Burbio that shows kind of schools that are closing across the country, and certainly in California, very low numbers, and where we are seeing it is in areas of low vaccination rates and or where staffing or the reasons for closures are just as much about potentially people being quarantined or staffing and logistical resources as opposed to large outbreaks. I think the other important thing to keep in mind is that outbreak is defined as 3 or more. The median number in schools outbreaks that we have seen is about 3 or 4 cases. So I do think with a lot of the testing we're doing on the indoor masking, and a lot of those requirements, we're doing quite well, again, especially if you look at the map across the country of sort of schools that have had to close because of COVID-19. And in fact, if anything, I think as many know, there's a lot of, as we're doing better, I think a lot of pressure and people are wondering, well, when can we stop doing certain things, which is why I really wanted to emphasize the importance of a lot of these measures. The other highlight I didn't bring up here was the recent studies about all the mitigation measures in youth camps, which are even higher risk because it's residential, really, right? Kids overnight together, and how when you use all those layers, you can actually prevent transmission. So I'd say overall we are doing well and continue to look at that. You know, we, as many of you have heard, we really have a mantra of trying to balance safe, meaning low to no transmission in schools, and successful, meaning kids are in person, because we've also are all seeing, you know, really the harms of kids not being in in-person instruction, and where is our sweet spot and balance of that, and how do we continue to titrate that as we see lower levels of transmission. And again, the answer to a lot of that is getting kids vaccinated. So we're really excited to have more.
Yes, with 8 and 10-year-olds at my house, I can't wait until we hear that decision, hopefully sooner rather than later. But I'll sort of follow that up with, I love the dogs who can sniff out COVID. And my first question on that, because we have a brand new puppy in my home as well, is how can we get my dog trained? And any of us, I mean, is this like a statewide training program? We can sort of put our dogs into the volunteer testing, you know, COVID sniffing force. That's actually a serious question. Are people thinking about that? And then, you know, the citizen dog sniffing. And then second of all, really is about tests. And so you can answer that first, but I was just in the UK visiting family, and you know, the families we were staying with have like gobs of tests because the NHS is handing out free tests and their schools are giving them free tests. And we're still so egregiously, in my mind, behind on testing in the States. And so I know it's really great news that the Biden administration has put a massive amount of money into really increasing the number of tests we have available. But I just wonder if there's anything that we can do at the state level or that private industry can do to kind of ramp up access to testing other than hire a lot of dogs who can sniff it.
Sure. So, and I'll have to get back to you about more of the details about the dog pilot. Right now, I think we are really very much in a pilot stage, but stay tuned and we'll get back to you. And yeah, great question about testing. And I think, you know, as you're mentioning, I think it's really a combination of the whole spectrum. So we're very closely monitoring kind of lab what I call brick and mortar lab capacity, and there, just like with healthcare, the late rating factor is staff, not really like lab equipment or capacity, but we do have a huge capacity as far as the equipment and brick and mortar way, like enough to do 800,000 a day in California, but you know, we're still needing to make sure we have waiving of certain requirements so that we have enough staffing and things like that. And then as far as, yeah, antigen testing, point of care testing, and now even more and more of the home kind of over the counter testing, we have been actively working with not only Abbott as a high priority, especially for schools. We've added on another vendor because of that, you know, moment when we were all very worried about the Abbott Binax Now supply. So we're now working, purchasing a large proportion as well from point of care testing called CareStart. And then, yes, as you mentioned, the Biden administration has just purchased even more home OTC tests. I think the rollout is really focused on certain high-risk settings. I do think the general supply is getting better as far as, you know, ability to get it yourselves in certain, you know, drugstores or point of care as well. And we're really trying to focus on high-risk settings in California. So we have definitely, you know, negotiated very large agreements with these different vendors for, again, schools is a huge priority, other high-risk settings like still nursing homes, incarcerated facilities, detention centers, like those kinds of settings are the priority. And we'll see, I think hopefully as the more and more technology around pooled testing and also the price continues to go down, I think that will absolutely help as well.
I'd say just maybe I can just add a little bit, because I actually wrote a paper with Michael Mina on that, because Michael and myself have been calling for rapid testing since the beginning of the pandemic, right? When I was in West Africa, for example, we developed rapid diagnostic tests for Ebola during the epidemic, and they were actually rolled out, and saw the big difference they made. I think what Michael and I were trying to say in that paper, I think the title was COVID-19, one test does not fit all, or something like that, is that we think too much about these as medical devices, which of course it's important. You can do clinical testing of suspected cases, right? You need a medical test. But the biggest utility is really in public health devices, in screening. That's why I distinguished between screening and testing during my talk, is that if you can get the status of individuals before they get into a restaurant, for example, or before they go to school, or before they go see friends, is a completely different way of thinking about testing than I think I have COVID-19 and can you please tell me? And there it completely changes of what the test, because it has to be very easy, it has to be very simple, it has to be cheap, you have to be able to do it often. And then the whole like obsession with sensitivity, for example, where it's like either it must be perfect like PCR, otherwise it's a useless test, is completely misguided, because as a public health test, it's all about lowering our RT, right? And if we can take away 9 people that might otherwise go out and infect people, not 10, but 9 out of 10, right? Well, that's better than 0 out of 10. And I like to compare this to seat belts in cars. Seat belts are not perfect either, right? But we don't stop using them because we're saying, oh, they're not perfect, so I don't want them. And I think it's really important that we keep this in mind, that as we're talking about testing, there's different modalities here, which again, I think Michael has done a really good job explaining that, because it is a completely different purpose. And in fact, sensitivity specificity is that things like specificity becomes much more important, right? Because you're now going to test a ton of people and you don't want all of them. Some of them are going to be, you don't want all of them to be false positives, right? Sensitivity is, while important, is less of a concern because you are going to capture the ones that are going to be most transmissible, so to speak.
Thanks for bringing that up, Christian, and thanks for your answer too, Erica. We did have Michael Mina on last winter and are hoping to get him on again to sort of discuss the evolution of our thinking about that. And I don't know if he's working on this with you, Christian, but I just heard him speaking and saying he's sort of thinking about writing out a strategic template, like how do we use these tests in a strategic way? So I'm excited to hear more about that. Christian, if I can ask you a little bit about future prognostication, and maybe Erica, you can lean in on this too. You know, all of us are wondering sort of what will happen next. What is the winter going to look like? When and if there will be a new variant. Is this variant got the perfect fitness that's going to stick around for a really long time? And I just, you know, knowing what you do about genomics, Christian, what are your thoughts on that? Can we make any assumptions about the future? Why don't you start there?
I mean, the easy answer is that I don't know, right? I think what I do know is that it's not stable, right? We're not going to be dealing with the Delta variant forever. We should expect other variants to emerge. We should expect the selection that will create those variants to be different, probably going to be more immune evasive than Delta, more so than just increased transmission. And that's what we should be planning for. And I think we are all so desperate for this to be over, right? But the longer we sort of keep like in this, well, false belief that we're almost there, every time the goalpost is moved. We've seen this repeatedly, right? Repeatedly, over and over and over again, that the goalpost keeps moving. And I think it's because we're not realistic over what we're actually dealing with here. We're dealing with a novel coronavirus that has been tearing through the entire world extremely rapidly. Like, I mean, the speed at which this virus has spread is just unbelievable. The evolutionary jumps we have seen of this virus, unbelievable. The false sense that the virus will become less pathogenic, for example, it will cause less disease. It's like, why do we think that to be true? It's because we, to a large degree, want that to be true. But what we observed is the opposite, right? So I think it would be wise to assume that we're going to have, you know, we need to keep fighting it hard, right? there is a future in which, with vaccines, with updated boosters, with all these things, that this is gonna fade into the background, and then because we have enough vaccine coverage, we'll sort of get tickled by the virus, but we'll get a little cold or whatever, be fine. There's a future that looks like that, but the problem is I don't know when that future is. It's not now, I can guarantee you that. This idea that it was 2 doses and done, that was never true, right? So I think it's really important that we realize that, and we keep fighting it with everything we have. And things like updated boosters are a very key component of that. And then I think also just being smart about it. The conversation around the J&J booster, for example, that people that got the J&J, which include people like myself, will need to get an updated or get a J&J as the booster shot. It's like, it doesn't make any sense, right? It's basic immunology we're talking about here, is that we have now seen that the mRNA vaccines provide stronger protection. So those are the ones we should use as boosters, right? I think it's here that we really need to consider that, again, we need to do everything we can and not wait for perfect data, but wait for enough data to make smart decisions and then act on those. And I think, again, that we have had during the entire pandemic, I'm not sure that we've done that at every step, right? And I think getting better at that, I think, is really important.
Thank you. And Erica, how do you, at the state level, it sort of has been, one response to a big thing, and then maybe you get a minute of a breather, and then you're back in fighting the good fight with the same tools. But you talked at the beginning about when we begin to think of this as endemic, and how is your response at the state level changing now that we're really seeing this pattern that Kristen's referring to?
Yeah, I mean, I think just to add and complement that, I mean, I think it's what's so important is that it is these multi-layered strategies, right? Like everybody wants a silver bullet, and our closest thing to it is vaccines. But to remind everyone, right, most of our vaccines actually have, or many of our vaccines certainly have, multiple doses. It took us years to know we would need a booster for MMR or a booster for pertussis, right? We know we get tetanus every 10 years. So, and as Christian's been pointing out, this virus is evolving much faster than anything we've dealt with. So it's not surprising, and it is part of our tools. And testing is important, but also not anything to do by itself. We all saw, the example at the sort of White House, they were testing people every single day, but they still had an outbreak. So I think it has to be all of these different layers. And I think over time, we'll be able to kind of peel off different layers. So I think that's how we've been kind of increasingly thinking about it. I think I would agree that I think it's going to take time. I think, even prior pandemics with flu, which again, flu is a really different virus, we're certainly learning, took 2 or 3 years to actually get through all of the waves and really get to a point. H1N1 was much milder, but that's our most recent pandemic, right, in 2009, and thankfully it was much milder. And it did become, part of our vaccine series, and then, just we saw less and less severe disease from it over time, but it did take, 2 or 3 years. So I think, and this virus, I absolutely agree. It's just faster, smarter. I mean, Delta really, the way I was analogizing Delta was, we did think we were like at the end of what I was calling the Iron Man, and then they brought in a different competitor who was fresh and stronger and faster and fitter, and they changed the course because we couldn't use as many of our tools. So I think we're continuing to have to adapt and really look, and I think that is the biggest challenge, and Kristen just said it as well. I think finding that right balance of as much evidence as we can gather to make good decisions for a large population, and then to do that and to be flexible. But I think I want to acknowledge too, it's really hard for the public when things evolve and change, and when policies change, and we're trying to do that, to be flexible. But I think there's confusion that ensues sometimes too, and so I think that also is what's been hard for everybody. And then there's the fatigue. But I do think, over time, again, but it really is going to be the whole world needs to be vaccinated. I mean, I think Christian put this beautifully, what did you call it, the mutation supply, I think, right? Until we can get rid of that supply, and then there's still going to be somewhat reservoirs. And it does seem like this virus can infect all kinds of animals. I mean, we've heard about sort of zoo animals, which is where we're getting testing, all many different kinds of species. So it's going to be with us and a challenge for a long time, but I think it will hopefully increasingly, we'll continue to use our different tools, and vaccines going to be the most powerful one that has the longest term impact, I think, that we will get to a place where this is really just sporadic or clusters. But I think because of the rapidity of this virus and because so many people are asymptomatic and infected, that makes it really challenging to ever get to kind of a smallpox scenario where we just got rid of it completely. But hopefully we can get to where we've gotten with many other vaccine preventable diseases.
Yeah, maybe just one point, because I totally agree. And I think because, people listen to me and they're like, oh, it's never going to be over, right? And I understand that. What I'm saying is that, look, it's a very solvable problem. We just need to put our minds to it. The problem is, again, that if we are hoping for these silver bullets, that it's like one and done, we're going to get, disappointed at every turn, right? I think the White House, for example, super spread event is a good example where a lot of people saying, look, they were testing at the White House every day and they had outbreaks, so rapid testing isn't working. I was like, no. Chances are that if they didn't do rapid testing, they would have had 10 outbreaks by now. And we don't know about the other 9 because they never happened, right? The tests prevented them. So I think it's really important that we just change our mindset and saying it doesn't have to be perfect, but you have the little Swiss cheese model of what you put them all together. And COVID is never going to go away, right? But that doesn't mean that it's not going to be much more manageable than it is today. And that future exists, absolutely exists. And things like vaccines and antivirals for the ones that the vaccine immunocompromised and cancer patients where it maybe doesn't work as well. All these layers are going to be incredibly beneficial, right? And testing and masking is very key there too. And I think with all of those things, if we realize that that's what we need to do for a while, it's immensely solvable, right? And will fade into the background.
Yeah, thanks for that. Maybe just for a minute, because Erica, you alluded to the fact that we have to vaccinate the world. Both of you really commented on that. But let's take a more global view. Christian, we've got a couple of questions, and you alluded to the fact that you had made some comments about emergence that maybe got a lot of attention. Do you want to take a minute to comment on your thoughts on emergence? And then also, just looking at this virus in the world, I have to say a lot of places that haven't had a lot of virus, as far as we know, have kind of baffled me. And so Africa is one that you've done some other work in. I am amazed that Africa has not been blown away by this. So maybe if you can comment a little bit on that.
Yeah, I think to the first point about equity, I'll say equity is the key thing, right? Because when I talk about mutational supply, I'm not talking about mutational supply in the United States, on California and San Diego, right? I'm talking about in the human population. And I think vaccine equity, getting people that don't have access vaccines, is critically important. And in fact, I've been calling for a Marshall Plan left, like World War II rebuilding, right, led by the United States, and look at vaccination to be that. That's what's necessary here. What I think is a little unfortunate, which I've also commented on, is that you conflate like the need for boosters with the need to vaccinate people that are currently not vaccinated, given limited supply, right? That is important, but the solution is that the supply. It's not saying like, oh, we don't need boosters yet. It's like, it's becoming clear that we do. And people like myself have literally been saying it from day one, that that's what we should expect based on what we know with other coronaviruses, immunity waning and the virus evolving, right? That we should expect that to be necessary. So let's make sure we fix the supply side of this so we don't end up with this false choice of having to do one or the other, when in reality we need to do both, right? And countries have the interest of doing the one can protect their own population the most first, so that's going to get focused. But more importantly for the mutational supply side is the equity, right? And I have all my colleagues in Africa, where yes, we work a lot in Africa, especially in West Africa, and the availability of vaccine is abysmal. And it's not their fault, it's our fault, right, for not making them available. And we absolutely need to fix that. Now, in terms of the burden of disease in Africa, I think maybe it is lower. The population is younger. They have many more coronaviruses circulating there. We have some data to suggest that actually there might be quite significant cross protection from other coronaviruses that might play a role here too, although we don't understand it fully. But also importantly is that, yeah, but there's also a lot of disease we just don't hear about, right? Reporting is a really important aspect of this, that if you don't test and if you don't look, well, you're not going to find. And that means that you're going to end up reporting less cases. Now, when I talk to my colleagues in West Africa and saying, what is your current situation right now, is that it's not as bad as it has been here in this country. So I do think that there is some difference in just, what's going on. Is it immunity? Is it maybe even resistance? Or is it just a lower burden because they're younger overall, right? That's a big open question. Now, to your last question about the emergence, are we talking about the origin of the virus, or are we talking about emergence in different areas?
Sorry, the emergence of this original SARS-CoV-2, I think was the question.
Okay. Yeah, I think, I think it's another perfect example of conflating a lot of different things, right? There's a lot of confusion in this space, and I'll say there's a lot of focus on the lab leak because Wuhan Institute of Virology is in Wuhan, right? But when you sort of cut away the speculation and innuendo, which is really driving the majority of the conversation right now, which I think is very unfortunate. If you look at like, what evidence do we actually have? And what do people that understand that evidence, because they have the expertise to actually look at this type of evidence, they've done these types of studies before, you look at all of that and the picture is pretty clear, although far from conclusive, right? That we see an early emergence like we have seen before. SARS-1 emerged in November of 2002 in a big Chinese city. SARS-2 emerged probably also in November in another big Chinese city, where again, they have supply lines of animals going in that are susceptible to these kinds of viruses, and then that distributes through markets in big cities. And if we look at all these early events, the clustering of the first hospitalizations all link back to the Huanan market. In fact, that's how they made the initial link, was at the hospitals. They noticed the link with cases to that particular market. We look at the cases, they all cluster around that market too, the early cases. And importantly, they're also the excess deaths actually also cluster around that market. The virus itself we find in the market, right? It's in environmental samples. Not only that, we isolated it from the market. The animals had probably been removed, so they weren't tested. Tested other animals that were frozen, but that's probably never where it came from, right? So I think it's really important that when we look at these things, we look at the actual evidence. And when I say evidence, I mean that, right? Something that is tangible, not something is saying, oh, I think they're covering up, but I think they're lying about this. So I find this a little weird, right? I'm talking about the evidence that's right in front of us, really suggests that what happened here is exactly what has happened multiple times previously, and in fact happened twice during the pandemic. 2 other novel coronaviruses emerged, right? Is that this is probably not just another example of that. Of course, we need conclusive answers to this. We need to keep investigating. We need to keep studying these questions, but realizing that it's gonna take time, we need to collaborate to do this. We can't hope to just do this in the US and not work with Chinese investigators, right? Of course, these are things that we need to figure out scientifically, as we've done previously. And currently is probably not really what's going on, right? But I'm certainly hopeful that we can get it back on track to do that.
Great, thank you for that. As usual in this speaker series, we have many more interesting questions than we do have time. But I really want to thank you, Erica and Christian, for being here with us today to really help us think through these important issues. And thank you to everyone who has listened in and taken time to view our webinar. Just a reminder, it is available at covidroundca.org, as our previous ones and our future ones will be. And we had a lot of questions today, very detailed questions about the vaccinations and also some things on long COVID, as well as on testing. And those are next month. We plan to have a couple of expert speakers talk specifically about vaccinations, particularly around the time of all the decision making that Erica really alluded to. That will be Tuesday, November 9th. So please tune in for that. And then in the next coming months, we'll have some more follow-up information on the prolonged COVID symptoms, as well as some things on testing. Just as a reminder, you'll be sent a survey at about 5 p.m. today where you can attest to your attendance. So don't forget that if you want CME. And thank you so much, everyone, and have a great day.
Thanks, everybody.
Thank you.
Okay. Thanks, Erica. Bye.
Thank you. Bye.